Today, we're talking about using POCUS to assess the right ventricle. And this is the second lecture in our series. The first was on LV function, and this will be on RV function, building on what we've talked about previously. And here you can see a list of other topics that I intend to cover in the future, but this is subject to change. And if you have any requests that are for topics that are not here, please feel free to let me know. The goal is to learn to interpret and not focusing on image acquisition, but interpretation of POCUS to assess the right ventricle. And our objectives will be to go through the various basic echo views, and this time looking at it with the lens for the RV. For RV function, what is it that you can see about the right ventricle in each of these views? I'm going to review some anatomy, going to integrate certain pearls, pitfalls along the way. I'm going to share with you qualitative and quantitative ways of assessing RV function. And at the end, we'll speak briefly about integrating this into practice. This is all going to be happening at once. We're not going through these one by one. I think presenting all the views and the discussion will integrate all of these objectives sequentially throughout the next hour. Before we begin, this is being delivered now asynchronously because I didn't record our live session. So I'll just share with you a brief starter quiz we did in the live session. And that was, the first question was, what is the best echo view for assessing RV function? Parasternal long, parasternal short, apical, subcostal. Please feel free to freeze and think about what you might answer, and I'll share with you what the group voted, which was 20% parasternal short, 80% said apical 4. Two more questions. Question number 2, McConnell sign is most specific for primary PH, pulmonary embolism, cor pulmonale, don't know. Pause to think, and then the answer that the group came up with was 60% specific for PE, 40% say that McConnell's is most specific for cor pulmonale. And final question. In general, how much pressure can a previously healthy RV generate acutely in response to disease? 40, 60, 80, or 100. And we had quite a spread of different ideas, the majority saying 40 millimeters of mercury. And with that baseline assessment, we will begin our discussion of the RV. Now, why would you be looking at the RV to assess function? When we spoke about the LV, we talked about how primarily you're looking at the LV systolic function to see if significantly reduced systolic function might explain a patient's hemodynamic state. For the RV, there's actually a little bit more that you can tell. So first, assessing the RV is helpful diagnostically, not only in the diagnostic algorithm of shock, but also for the diagnostic workup of hypoxemia. But additionally, and this is something that I mentioned to our fellows when we talk about shock, sometimes POCUS is not necessarily needed to give you the specific diagnosis or the specific answer. Very often, especially in the complex patients that we have in our units, patients have multifactorial complex diseases that are contributing to a complex hemodynamic state. And so the purpose of POCUS isn't to say, oh, this is a PE, oh, this is pericardial this is tamponade. Sometimes the purpose is really just to guide your inpatient ICU management. So maybe you'll be choosing your pressors or your inotropes, or maybe you'll be reaching for pulmonary vasodilators based on what the RV is doing in the context of everything else. Maybe you're putting the patient on mechanical circulatory support and you want to choose whether you're going on VV or VA, or VV with a Protec, which is an RVAD. Maybe you're just assessing the patient's volume status, which is going to be the topic of a future lecture. So being able to assess the RV is extremely impactful and can impact your management in several ways. Now, before we jump in, I think it's important to keep in mind RV geometry and RV anatomy. So I'm going to discuss that briefly in these two slides. You might at times have heard the RV discussed as having a crescent shape, and you might have heard the RV being described as having a triangular shape. And as you might be able to see from this geometric reconstruction, both are true. So when you're looking from the top down, and this is something that you'll see in the parasternal short axis view, the RV wraps around the LV and does create this sort of crescent. At the same time, if you're looking at the RV longitudinally, it has this more triangular shape, and I'm going to be pointing that out to you when we're going through the views later. And when the RV is in disease, you can see how dramatically the RV is able to dilate and become baggy and globular in appearance. Now, in discussing RV anatomy, it's also important to recognize that Similar to the LV, the RV has, cardiac muscle that is oriented in different orientations, but the predominant one seems to be longitudinal fibers, these vertical fibers that you're seeing. And that means that the RV systolic function has what's often described as a piston-like motion, just like you're seeing in this GIF over here. And we're going to be seeing that when we're looking at the TAPSE and assessing RV function in one of the window views. But it's important not to forget that the RV also has latitudinal fibers or longitudinal fibers, however you want to describe that. And they also have an important impact and an important role in systolic function. They create what's sort of a bellows-like effect, where there's contraction inward, not just longitudinal activity up and down, but also inward. And that's something that we'll keep our eye out for when we're looking at the RV in multiple views in just a few minutes. So I want to begin by going through these views that we went through when we discussed the LV, but this time focusing on the RV and picking out what it is about the right ventricle that you can see at each of these views. So you'll remember that this is your parasternal long axis view. Over here you have the left atrium, left ventricle, aortic valve, LVOT. And the first question before we discuss the RV again is, are we on axis? And to quickly review, you're able to see both valves opening and closing. You're seeing them head on. You're seeing the aortic valve closing with the coaptation point in the middle here. You're seeing about 2/3 of the left ventricle, and you're not seeing the apex. So as far as we can tell, this is a view that is a parasternal long axis view that is on axis. Now that we know we're on axis, we can take a look at what else we're seeing, and that's right here. What we're seeing here is the right ventricular outflow tract and RVOT. And the question is, so that's all we're seeing. We're not seeing the RV inflow tract. We're not seeing the RV apex. We're just seeing the RV outflow tract right before it's going to go through the pulmonary valve. And what's normal? Well, what can you say about the RVOT? On this view, you can really just comment on size. And that's it. That's all you're really going to be looking at. So when you're going through your window sequentially and you're taking a look at the RV and you're curious about RV function, when you're looking at this view, you're going to be logging in your mind, what is the RVOT size? Now, if you want to be a purist and you want to go and take your advanced critical care echo boards, you can literally pause, measure, and normal, it should be less than 3.3 centimeters, right? Now that's not terribly difficult to do, but it's probably not something you're going to want to do on a regular basis. And if you're not taking your advanced critical care echo boards, this is probably not the most important thing to know. What's probably more practical is that in the RV, eyeballing is actually, in my view, much more straightforward than eyeballing the LV. And in this case, you can eyeball using the rule of thirds. And the rule of thirds is that in the parasternal long axis view, your left atrium, your LVOT, and your RVOT ballpark should all be the same size. And so if one of them is much larger than all the others, that's probably enlarged. So that's an easy way to help eyeball. So as you can see in this view over here, we have what's probably an enlarged left atrium, a normal sized aorta, and also a comparatively very large RVOT. So you don't have to measure this to know that it's greater than 3.3 centimeters. You can just use your rule of thirds to realize that this RVOT is pretty large. This is a good moment to say that you should, and I'll point this out later in the apical forechamber, you should not use the rule of thirds to assess whether or not you're on axis, right? Because you will not be able to use that in cases of pathology. So whenever you're thinking about things that will show whether or not you're on or off axis, you need things that are going to be true whether you're normal or healthy or whether you're looking at a diseased heart. If your orientation and your determination of whether or not you're on axis relies on normal, then you're not going to be able to recognize when you're seeing abnormal. And I'll illustrate that later. Now, sometimes you don't even need to know the rule of thirds. That's a situation like this. This should be the parasternal long axis view, and you can sometimes see here the left atrium, left ventricle, LVOT. But the RVOT is so large that it's taking over the entire window. And this is what I have named the RV takeover sign. So please use it and spread it so that I can become famous. It's the RV takeover sign. And to me, that's when you put your probe on expecting to see a parasternal long axis, but instead you're just seeing a really large RV. You don't need to measure it. You don't need to know the rule of thirds to know that this is an abnormally large RV. And since I brought up the 3.3 centimeters, though, I'll take a brief moment just to share for anyone interested again in pursuing the critical care echo boards, or if you're ever looking for the authoritative source for cutoffs and dimensions when you're doing echocardiography, the primary source is the ASE. You might see different numbers in different places, but in general, there seems to be consensus that if you're looking for a default source to rely on, it's the American Society of Echo. They publish guidelines that are available for free on echocardiography. And so if you look for their guideline on assessment of the right heart in adults, which hasn't been updated since 2010, you'll see this table, which gives you all the dimensions for all the different things you can measure. And you'll see RVOT, parasternal long axis, proximal diameter, greater than 3.3 centimeters, abnormal. And for anything, any numbers that come up here, if you ever want to double check them, or if you ever forget them, or you want to know the source, it's from the American Society of Echo. Now that's all I have to say about the parasternal long axis. Now I'm going to bring us to the parasternal short axis, and you might recall that the parasternal short axis has several levels: an aortic valve level, a mitral valve level, a papillary level, and an apical level. I'm going to be starting bottom up. There is no apical level. At the apical level, you usually do not see the RV, so I'm going to start us at the papillary level. And the way that we know that we're on axis here is to some degree that we're circular and not like an oval, although we're going to get to the D sign soon, and that doesn't mean necessarily that you're off axis. And at the papillary level, you want to see both papillary muscles, and they should both be this nice bean-sized shape. And that's really the best we can do in determining that this view is on axis. And so again, though, before we say anything about what we're seeing, you want to make sure that you know what level you are. You're at the parasternal short axis papillary muscle level, and we are on axis. Okay, so we're on axis. Well, now what can we say about the RV? So here you have the RV wrapping around. This is doing some of that crescent that we were talking about earlier. And there are a couple of things, two things you can say about the RV in this view. The first thing you might be able to comment on is size. I don't have specific cutoffs for you, and there could be quite a range. I think later on I'll show you a clip where you will obviously see that the RV is enormous. Certainly if it's larger than the LV, that would be abnormal. Sometimes it can look a little bit large, not as large as the LV, and you might not be sure, and there isn't a great way to measure or prove that something is enlarged. So it's just something to keep in mind. But the much more impactful point to look at when you're looking at the parasternal short axis view in terms of the RV is septal kinetics, looking at this interventricular dependence. You note that, we see this septum right here and it's part of the LV, but don't forget that the septum is actually a substantial portion of the RV as well. The RV very much depends on the septum, and RV filling pressures, RV dynamic pressures also will impact the septum and can impair LV filling, and I'm going to demonstrate that for you in a little bit. So you're going to be looking at this septum and seeing how things can go wrong. I'm going to dive into that a little bit shortly after I go through the rest of the RV views. Here, we're now moving our probe up, and we are seeing this opening and closing fish mouth appearance, which tells us that we're at the parasternal short axis at the mitral valve level. It's nice and circular. We're losing some of this to some artifact, but this is normal. And here you have the RV wrapping around. It's a crescent. It looks a little bit larger than the last one, but still normal. And at this level, I just went through how we know that we're on axis. What can you say about the RV? About the same things that you could say at the papillary level. You're looking at size, and you're looking at septal kinetics. Now, I thought this would be a good point to quickly review the LV segments, because I discussed at our last lecture that the LV has 17 segments and they all have names, and it's worthwhile to get to know what they are so that you can communicate what you're looking at each heart, and it's on a given echo, and it's actually not all that difficult. So it's 6 at each level: the mitral valve or the base, then you have the papillary level or the mid-level. Those each have 6 segments that have the same names, just at different levels, and that brings you to 12. Then at the apical level, there are 4 segments, and then the apex is the 17th segment. Now, the way you name these, again, this is just a review that doesn't have to do with the RV, is you see here that you have the entire septum. It starts here, and it ends here. So that next to the septum, immediately in the front here, is the anterior segment. The anterior, it's anterior because your probe is on the patient's chest, and whatever's closer to your probe is anterior. The other end of where the septum meets the rest of the heart, that's inferior. Everything else here, this is the septal wall, anterior, inferior. This is your lateral wall. And your septal and lateral wall are divided in half, and they're named by whether or not they're anterior or inferior. So you have anteroseptal and inferoseptal, anterior wall, inferior wall, anterolateral, inferolateral. And so that would be how you would name your 6 segments at the basal level. And then you would say, if you were at the papillary level, they would have the same names, but you would say at the papillary level. At the apical level, when you can still see all the walls, but the septum and the lateral wall get smaller, they lose their delineation into 2. So you just have anterior, septal, inferior, lateral, and then the apex is the apex. And so now you can hopefully pretty intuitively name all 17 segments. But back to the RV. So now we're at the aortic valve level. This is perhaps the most confusing level to get comfortable with, and it has a lot of information about the right ventricle. So remember, here we are at the aortic valve. So the left ventricle is beneath us, but the right ventricle sort of creeps up, and so we're actually seeing a lot of RV. So to go in order, so again, are we on axis? The best way to see is that you have the aortic valve and it's opening on face. You see the leaflets are all opening up, and you have this opening in the center. So that's one of the best ways to know that you're on axis on this parasternal short axis aortic valve level. And what are we seeing of the RV? Well, this right here is your left atrium. Right here, you have your interatrial septum. It's very, very thin, so at points it looks like there's nothing there. Then you have your right atrium, and this right here is your right ventricle, which would make this little flopping leaflet thing here your tricuspid valve, and this your pulmonic valve. You can actually, on a good day, go a little bit further and see, well, after the pulmonic valve is your pulmonary artery. Now take a look at this diagram that we showed you at the very beginning. This here, this crescent, is this crescent, right? This is where your aortic valve rests, and you're seeing this crescent shape. So this is also flipped. Here's tricuspid, here's pulmonic. Over here it's tricuspid, and this is pulmonic. That's just by virtue of how we've standardized holding the probe. But in general, what you're seeing here is the RA pushing blood into the RV, and it's going down, and then it's coming back up over here at the pulmonary valve level. Now, moving along, you can notice that if you zoom in, or also on a good day, you're sometimes able to get a good look at the pulmonary artery, and you can even see where it bifurcates and becomes the right pulmonary artery and the left pulmonary artery. And this is sometimes called the man with the pants sign, pulmonary arteries bifurcating into right and left. And this is an occasion where sometimes you can even see a saddle pulmonary embolus on this view. So let's get back into the septum, and here we're at one of the papillary muscle levels. Now, you are probably noticing that this is extremely abnormal, and here you're having what's called the D sign. And it's called the D sign because the septum usually flattens, whereas the rest of the LV remains circular. So you have a flattened septum, circular D shape here. You might also appreciate that we have a pretty large RV here, and it's impacting the LV, and it's making this D shape. Now let's take a look at this one over here. You might appreciate here too that we're getting a D shape. But there's actually a difference between the D that you're seeing here and the D that you're seeing here. You might say, well, this just looks more dramatic, and that's true. This looks more severe, and that's true. But another difference is that this D shape is actually only happening in diastole. If you look closely, as the ventricle expands, this flattens, but as it closes inward during systole, it becomes a circle again. So if you look, closes becomes a circle, opens becomes a D. Closes, again, becomes a circle. So what does that entail? What does that reflect? Well, that's sometimes referred to, the distinction is sometimes referred to as pressure overload and volume overload. The first thing that we saw is pressure overload. That's when you have a D sign in systole, usually and diastole as well. And that's due to a significant increase in RV pressure, often also due to an increase in RV mass, where throughout the cardiac cycle, the center of gravity, so to speak, of the septum is still pulled rightwards, so you're going to get a D shape. You're going to get a D shape throughout the cardiac cycle. in volume overload, you're getting that increased volume just in diastole, and that, of course, also creates an increase in pressure, which pushes the septum over. But this distinction is used to demonstrate that when you're getting the D sign only in diastole, that increase in pressure is driven by an increase in volume. And so when you see that diastolic flattening that's not there during systole, that's usually a sign of a volume overloaded RV. But when I say volume overloaded, it's important to be careful because you're probably thinking, oh, this is a patient who we've over-resuscitated, a septic patient who got too much fluid. And that's possible. But there's also an ASD, tricuspid regurg, pulmonic regurg. There are things that can be going on intracardiac. So you can have intracardiac volume overload without having systemic volume overload. So this is not used to necessarily determine volume status on a patient. In the right clinical context, it might. It's important to recognize that the heart could be volume overloaded for any of several reasons. But the important point of this here also is to not just look at a D sign and say we have a D sign that's RV strain and go down your RV failure or acute RV failure algorithm. It's in order to really be able to distinguish the different types of RV dysfunction that you might be seeing. Now, moving on to the apical four-chamber view. And again, how do we know that we're on axis? Well, you have the apex up at the top. You have the heart coming down at this longitudinal ice cream cone shape, which I'm going to show again in the future. You have the right over here and the left over here, not just by convention, but also because the RV, the tricuspid valve, inserts more apically than the mitral valve. That's true across disease and across health, across even most congenital diseases. Now, this is another point where I would bring up this is the other time where I intend to bring up the point of trying to be careful and wary of using normal anatomy to help you determine whether or not you're right or left or whether or not you're on axis. For example, in general, the LV owns the apex. So if you see that this apex is here, you'll say, oh, that this must be the LV, and you're not flipped, you're not rotated, you didn't mix up right and left. But that assumes that this isn't that this is not a diseased heart. But in diseases we're about to see, in a significant RV dilation, the RV might own the apex. And if that's the case, and if you're using where the apex is to determine what's right and what's left, you're going to get confused. So again, important to understand the anatomy, look at the tricuspid valve insertion, the true details that determine whether or not something is correctly oriented. Now, what's going on at the RV apex over here? You might pick up that there's some weird things happening. So I'd like to remind you that there are significant trabeculations in the RV, and that's what you're seeing here, in addition to a moderator band, and that's what you're seeing right here. Moderator band carries some of the His-Purkinje system, and if you're overgained or angled a certain way, you can sometimes make it look like this, which is one of my early echoes, where I saw this and I said, oh boy, we have an RV thrombus. It's really good that I started learning critical care echocardiography. And then you get a formal echo and they see this and they say, well, this is not an RV thrombus at all. And you begin to realize that this is really just some artifact reflections off of the moderator band. And it's actually quite a common thing to see. So something to look out for, to be wary of before overcalling. Now, in my view, I asked what's the best view for RV function, and I believe that the apical four-chamber view is the best view for assessing RV function because you can see 5 different things here, things that you can't see, and you certainly can't see all of them in other views, although certainly this is a little bit subjective in the terms of which view is the best. But what I'd like to do now is go through 4 out of 5 of these. I'm going to leave TRJet and RVSP for a future talk because that relies on spectral Doppler and understanding a little bit about Doppler physics that I thought was too much to force into this talk. But I'm leaving it here for the sake of completion. But from the RV view, from the apical four-chamber view, you're able to first look at RV size. And again, if you were interested in taking your echo boards, you can learn how to freeze it, you can learn how to measure it, you can learn the cutoffs or the basal diameter, the mid-level diameter, the longitudinal diameter. I'm not putting them up on the screen because I don't think that they're important. Because again, the RV is actually much easier in some ways to eyeball than the LV. And that's because to assess RV dysfunction, or at least RV dilation, one thing that you can do is know the following, that the RV normally should be 2/3 the size of the LV. If the RV is equal in size to the LV, then it's considered moderately enlarged. So you don't need to measure anything. You really just need to compare the two. If the RV is greater than the LV, it's severely enlarged. Now, if you want to make this 1 ounce more complicated, you could say, well, if it's greater than 2/3, but not equal to the size of the LV, then you can call that mildly enlarged. But I intentionally left this out because that's not really helpful, because I don't think that we're going to be making significant calls from a mildly enlarged RV in our patient population. And if you're not sure and you're hemming and hawing about, well, is it equal or is it slightly bigger, also doesn't matter. The point is that you've identified moderate to severely enlarged RV. And if you think that that is an acute change, then that's important. If you think that it's old, then maybe it's not important. And assessing chronicity is something we're going to touch on as well. This is, like I mentioned, always important when you're doing echo to know your baseline, to know what to change and what's not. But again, you don't need to measure things. You can just look at this RV and see that it's bigger than the LV. This is a severely enlarged RV. And notice that, as I was alluding to, or as I mentioned earlier, the RV has now taken over the apex. And you might also appreciate that there's actually a clot down in the RV, at the RV apex. Now, a couple of caveats, things to look out for, common pitfalls when you're taking an apical 4-chamber view. The first is that, I mentioned you usually want to have this bullet shape LV, RV, bullet shaped ventricles to atria. And you can see that this green echo correlates with this green echo probe, which is perfectly slicing the heart in its midline. If you were fanned upward, you might catch just a small edge of the LV and the atria fully, such that you get these very egg-like, large, circular, globular ventricles and atria. Now, certainly it could be that this is actually you're on axis and this is a very diseased heart, right? Keeping in mind the caveats that I mentioned earlier. More often than not, this is going to be you're being foreshortened and needing to correct your angle. And the best way to learn how to appreciate that is to keep trying to get something that looks bullet shaped and looks egg shaped versus something that looks egg shaped, and learning this skill over time. This is the ice cream cone shape. Some people say bullet shape. I like the ice cream cone, but take your choice. The other thing to recognize is that depending on how you're rotated, not how much you're tilted or fanned upwards or anteriorly, but how much you're rotated along the clock, you could cut the LV and the RV at a different, and I know this looks like a parasternal short axis, but it's sort of getting at how you're aiming your probe up from the apex through the atria. You could be number 3 and look like you have a totally normal heart here. But as you rotate your probe and really get it through its largest dimension, you'll find that your RV actually might be larger than you think. And so again, rotating your probe, even when you're already at that ice cream cone, but rotating your probe to maximize the RV will ensure, while not losing the LV and not losing the features of being on axis, both valves, will help make sure that your RV size is correctly being measured. Now, moving along from RV size to TAPSE, and this is something I won't dwell on too deeply because I went through how to measure it and what it means when we discussed MAPSE. But here is where you're looking at your tricuspid annulus and you see how it's moving longitudinally towards the apex quite rigorously. And this reflects that piston movement that I showed you at the very beginning of this talk. RV function going up, up, up. It's really squeezing its contents in a longitudinal pattern. And so we can actually measure how much distance this annulus, this triangular fleshy annulus, is moving using our M mode by slapping an M mode cursor over the annulus and looking at it over time. And you can see that this reflects the annular motion up and down. As it goes up and down, it gets caught by the M mode. And if you measure that distance, this clip brought to you by the Society of Cyrus Jesudasin, you can measure this and see that it's 27.3. Abnormal is less than 16. Normal is really in the low 20s, but anything up until 17 is still considered within above the lower limit of normal. Once you get below 16, that suggests that you have impaired function, that the RV is not doing its longitudinal motion that it should be. And I'm also just reminded here to tell you that if you have a violated pericardial sac, someone had a pericardiotomy, you'll not be able to use the TAPSE. It's not been validated for that patient population. So a lot of patients in the heart center, you won't be able to use your TAPSE. Now here's a normal, and here you can see an abnormal, where you're measuring that TAPSE and you're seeing that annulus is actually only moving a tiny bit. and you're getting a total of, this is from Louisa Mounsey, and your TAPSE here is 15, so that's going to be abnormal. Again, if you have trouble understanding this concept, I think it's explained better in our LV systolic function when we discussed MAPSE. The other thing I just wanted to point out is that sometimes if you know you're on axis, you might be on axis but still have very poor windows, ARDS, edema, for whatever reason. Sometimes you can still pick out a MAPSE, which is sometimes useful. One major limitation that I shared in the last talk, but is worth repeating about using the TAPSE. So what you're doing is you're really assessing how much this annulus is moving, and you're making a claim about RV function, global RV function from a focal measurement. This assumes homogeneous activity of the right ventricle. But it could be that your annulus is moving well and the rest of your heart, due to an MI, some other dysfunction like we'll get to later, is not functioning well. And so you don't want to miscommunicate and say, well, the TAPSE was normal, so RV function is normal. This is why you have to incorporate a holistic approach and be looking at all the other parameters that we're talking about today before really making a call about RV function. You don't want to just look at a TAPSE and make a call about RV function. The other thing is that the TAPSE has been validated when you're taking it on axis. So if you're getting an apical 4-chamber view off axis, which is unfortunately often the best we'll get in the ICU, you might not be able to use your TAPSE, right? So if you're oriented in such a way, now you can't make the M-mode cursor come like this. Your M-mode automatically starts from the tip here and has to be carried over. But if the way you're oriented is such that your M-mode is directly over the RV, it is my view that you're going to be overestimating your TAPSE, because you're getting this full longitudinal motion, whereas it's only been validated to sort of get it off at a little bit of an angle. I haven't seen that written anywhere. People might be disagreeing with this, but what no one would disagree with is this, that if you're getting off an axis and you're completely at this oblique angle, you're really losing a lot of that longitudinal vector. And so you're going to very much underestimate your TAPSE. The major point to remember also when talking about TAPSE, though, is that while you might measure it once or twice and get used to how to measure a TAPSE, at some point after you've measured it enough times, you'll be able to just look at this annulus and see how well it's moving with your eyes and know whether or not it's normal, hyperdynamic, or super abnormal, super reduced, and you might not need to continue measuring it on a regular basis. And that's, I think, the purpose of learning some of these quantitative measurements, like I mentioned ad nauseum in our first lecture, is to know how to measure quantitative measurements, do them enough times to get comfortable with them so that you don't have to do them again. Moving on to fractional area change. And this is not something that I think anyone should be measuring, but it's something that I wanted to bring up to make a specific point, because very often TAPSE sort of just becomes the go-to and has gotten a lot of good PR in terms of assessing RV function. And it makes people sometimes forget to look at one other component of RV function, and that is the bellows effect that I was referring to earlier. And that bellows effect is where you see this free wall of the RV compressing inward and reducing the area of the right ventricle. You will see, and I'll show you a clip soon, where you have a TAPSE that kind of looks okay, but there's actually no bellows. There's no change in the internal area of the RV between diastole and systole. And that's called fractional area change. And so you want it to be around 60%. And so in theory, you can pause in systole, pause in diastole, you can trace it, have the machine measure. This is what a fractional area change of 60% would be. Or you could try to train your eye to sort of just get used to the difference between normal changes in area, a normal bellows, and an abnormal bellows. Right here, you might appreciate that the difference between systole and diastole is even less. This is a fractional area change of 40%. And here you have an enlarged RV, the apex is taken over, and you're barely seeing any difference between diastole and systole. You might have a TAPSE that's moving for whatever reason, but you're not getting that bellows effect. You're not getting a change in fractional area. So again, not saying anyone should be measuring this, not saying that you need to speak in terms of fractional area change, but don't get lost in the TAPSE and forget to look at the free wall that's contracting and how much that area of the RV is moving. And then everyone's favorite, the McConnell sign. So what is McConnell sign? So it's been described in the original paper as a distinct regional pattern of RV dysfunction, with akinesia of the mid-free wall, but normal motion at the apex. So you're used to seeing this apex was just invaginating maybe normally. This mid-free wall, not really moving very much. Your TAPSE actually, your tricuspid annulus actually might be moving. And this is exactly the point that I was just discussing, where if you looked at fractional area change, for example, not much fractional area change, whether or not you measure it. TAPSE might be normal here, but mid-free wall is not doing anything, not participating in the bellows effect, whereas the apex is still functioning. Here's another example of the McConnell sign. So you have the apex doing nice, rigorous function, this mid-free wall doing nothing, your TAPSE, your tricuspid annulus doing a little bit. And I bring this is another image I found. This is from the POCUS Atlas. You can see these online. This is someone who actually were in the parasternal long axis view, a little bit off axis, but you have the left atrium, left ventricle, aortic outflow. I thought this was interesting because you can almost see some RV apex here, because you shouldn't normally see RV apex in the parasternal long axis view, but this is a little bit off axis. You could see some RV apex, and you even get a whiff of McConnell sign over here on this view. And it's just an interesting finding sometimes that you might be able to appreciate as you're scanning your patients through the parasternal long axis view. So getting to the question that I asked everyone to begin with is, does McConnell sign equal a PE? Very often people seem to think that it does. And if you look at the original paper, Regional RV Dysfunction Detected by Echo in Acute PE by Dr. McConnell, who was at the Brigham at the time, they studied 41 patients. 18 were healthy, 9 had chronic primary PH, and 14 had a PE. And so they found in this study that it was 94, that McConnell sign was 94% specific for PE. And this has carried over and has led to people ascribing a 94 or a high specificity of McConnell sign for PE. But I asked our live audience if anyone had a problem with this study, and people did. And the problem with this study is that they compared, okay, we had healthy patients. You were comparing chronic RV dysfunction with acute RV dysfunction. But they didn't look at a group of acute RV dysfunction that for a different etiology, for cor pulmonale and ARDS, pneumothorax, right? So people have criticized this idea and said that, McConnell sign doesn't mean PE. McConnell sign is just something that happens in acute significant RV dysfunction. And until proven otherwise, this is true. And so unless you have an echo that looks like this. And here you have McConnell sign, you have invagination here, you have no free wall movement, and you have a jumping around clot inside the RV. In this case, you could be pretty sure that this is a patient who has having RV dysfunction from a clot, from a PE, although even then, maybe not. But at least here, you're going to be treating this patient as if they have a PE regardless. But otherwise, McConnell sign more likely means acute RV dysfunction, does not necessarily mean a PE. Now, finally, I mentioned that I'm just putting this here to show briefly that the apical four-chamber view is one of the best views to get a TR jet. You can see it in other views as well, in the parasternal short, at the aortic valve level, at the RV inflow view, which we'll talk about in a future lecture. So I'm not going to get into that here, other than to just show you that it's here and that we're going to talk about it, and that's another great use of the apical four-chamber view when you're assessing RV function. And I'll also share with you now the answer, which is that in general, of course, it's not the same for every single human, but in general, an RV that's previously healthy could generate up to 60 millimeters of mercury in a pressure in response to an acute change. And so when you have a patient who has an RVSP of 100 and you're not sure is this acute or chronic, well, it might be acute on chronic, but there's almost certainly going to be a chronic component to their pH or to their RVSP. Now, finally, looking at the subcostal view, we went through parasternal long, parasternal short, apical 4. We're up to the subcostal view. If this is on axis, this is actually sometimes also a helpful view for looking at RV size compared to the LV. Again, you have to make sure that you're on axis, and it's very difficult sometimes in positive pressure ventilation, intubated patients, certainly obese patients, to really get an on-axis view and not to be slicing it at an oblique angle. But if you could convince yourself that you're on axis, you could use this to look at RV size. This is also one view where you can look at RV free wall thickness. That's over here, but you have to be able to look really closely so that you're not mixing it up with the liver, you're not mixing it up with pericardial fat, and you're really just measuring RV free wall thickness at end diastole, not at systole when it's thickening on its own, but at end diastole. And there's conflicting data, but that suggests that greater than 5 millimeters is a sign of chronicity, is a thick RV and is a sign of chronicity. That greater than 1 centimeter might be even more chronic or more severe. So this is there aren't many great clues other than RVSP that I just mentioned to help you determine whether or not RV dysfunction is acute or chronic. So this is just one of the other clues and cues is looking at RV free wall thickness. The other thing you might be able to get once we're talking about the subcostal view and teasing a little bit about color is that you have the LA, the RA. Sometimes you might be able to see a left to right ASD using color, although very, very difficult to find. And often, if you're worried about ASDs, you're still going to need either contrast study if it's going to be right to left, or excuse me, an agitated saline study, especially if you think it's going to be right to left. One other fun fact, once we're discussing the RV and looking at the subcostal view, is does this patient have a pericardial effusion? So I'm actually not sure, but the reason why I'm not sure, and not just saying yes, is that many patients have an epicardial fat pad overlying the RV free wall, and it can look, because it's just very thin tissue, it can look almost echolucent like you're seeing here. And in fact, if I didn't have the next clip that I'm about to show you, I would have suggested that this is an epicardial fat pad. And some clues is if you could see some echogenic material within that space, that might be a sign that you might be seeing some of the tissue of the fat. But if you're overgained, you might see it. If there's a bloody effusion, then that could also have some echogenicity to it. The other thing is if you see that echogenic material and it's moving with the heart, that would also be a sign of epicardial fat. And I actually thought that was the case with some of this. So I thought this was an epicardial fat, and it might be some epicardial fat. But when I was in the parasternal long axis view, there is what seems to be a circumferential effusion. If there's an effusion on this side, then there's probably effusion here too. There could be some of both. Some of this could be epicardial fat and a trace effusion. Neither of these are dramatic. We're going to talk about tamponade another day, but I just thought this was a good opportunity to share this important piece of information, to know that you can have an epicardial fat pad that looks like a pericardial effusion. So integrating this into practice, I think there's an important thing to some important takeaways. So I'll share with you a case. You have a 52-year-old woman with a BMI of 40, has an ILD on 2 liters nasal cannula, followed at an OSH, so you don't have any past medical history, admitted with hypoxemia and shock, and you don't have a trope or BNP, and there's no prior echo in our system, and it's this. So we're not live, so I'll have to just walk us all through it, but we're in the parasternal long axis view, and this is what I call the RV takeover view, where a RV takeover sign, where the RV is playing the primary role, is taking stealing the show in this view. You're on axis, you have the LA, mitral valve, LV, aortic valve, aortic outflow, but the RV is significantly present. And you might even be able to appreciate that some of that septum is bowing into the LV. So you can expect a pretty prominent D sign when you're going to be looking at the parasternal short axis. And here it is. And you might think, and it's possible here, that you're on the parasternal short axis at the mitral valve level, very large RV. I don't think anyone needs to be an expert to see that. And if you look closely at this, if you pause the video, you might convince yourself that this is RV volume overload, that in systole, when the RV is contracting, and it's becoming a little bit more round. And as it's dilating and diastole and filling, it's becoming a little bit more flat. But that might be a little bit of a soft call. Go a little bit further down at the papillary level view, still seeing a large RV, still seeing this D sign, looking like a thick LV as well. And here you're at the parasternal short axis view at the aortic valve level, and you might appreciate what seems to be a large right atrium and RVOT. If you measure this, you'll probably see that it's large as well. And if you put color on it, you'll actually see some significant TR. And again, not the topic of today, but this is another one of the views where you could see significant TR. And sneak preview, when you talk about RVSP, this is how you would measure it. This is one of the ways you would measure it. This is what it will look like. Not as scary as it looks, but I'll just point out for the purposes of today that the RVSP on this patient was 42. There's some caveats. In torrential TR, this whole system might not work, but nevertheless, we'll take this RVSP as 42. And we're looking in our subcostal 4-chamber view, and I'm not perfectly on axis here, so I don't want to make too many calls, but I'm just showing it to you for the sake of completion. Finally, you're looking at the IVC here. It's not super plump. It's not super large. This right here is about probably 2 centimeters, so actually could be. I should correct myself. This is 25 centimeters deep, and one of the things I always remind people not to be fooled with is that when you're very deep, IVC could look small if you don't measure it, but this is 25 centimeters. Each of these distances is probably 2 centimeters, so that could very easily be over 2 centimeters. you might see that the IVC looks like it's pulsating. You might ask yourself, is this the aorta? But it's not the aorta because you could see it falling into the RA. You can see the hepatic vein entering. This is probably some movement from TR. And again, we're not really talking about color today, but this blue flow that you're seeing occasionally in the hepatic vein, that's blood going backwards. It should only be red and going from the hepatic vein into the IVC, into the RA. That occasional bursts of blue, that's TR that's going retrograde. That's also probably explaining why it's having some of this bounding nature in the IVC. And you look at the apical four-chamber view, and you can see that the RV is significantly dilated. It's larger than the LA. Than the LV. It's owning the apex. Don't know if I'm seeing clots there. Our TAPSE, which I don't think I measured for us here, is not good. You don't have to measure it to know that that annulus is not moving very well. And you might have some McConnell sign here where there's some movement over here at the apex, not much movement here from some of that mid-wall. And again, at this view, you're able to see some pretty significant tricuspid regurgitation. And so I think we can all look at this and be pretty convinced that we have the eyes now to see that this is severe RV dysfunction, but that's actually not the end of the discussion. And the question is, well, why does this patient have RV dysfunction? And I'm hoping, in somewhat as a teaser, to clue you into other ways that critical care ultrasound, not just of the heart, can help with this differential diagnosis. So your differential diagnosis is, of course, everyone's going to be thinking about a PE. It could also be acute cor pulmonale in ARDS. Big distinction there about whether or not you're going to be anticoagulating. This could be just a patient with chronic PH, and this could not be necessarily the cause of their acute decompensation. We don't know this patient, right? So maybe this is not the reason why this patient is here. It could be acute on chronic PH, where they had PH and now they have this on top of it. Or maybe this patient had a pneumothorax and has significantly increased intrathoracic pressure, and therefore you're getting obstructive shock. So lots of different things. So you're seeing this, the echo would look the same. You'd have this severe RV dysfunction, right? A dilated RA, that might be the cause of the TR, but you still have quite a wide differential diagnosis. So what do you do? So one of the first things you want to do is try to tease apart whether or not it's acute or chronic. I think if someone's in the ICU and you see that, even if you don't know them, you'll probably be assuming that this is related and not just an innocent bystander. But any prior echo or imaging, of course, will be extremely helpful in making that determination. In this case, the RVSP was 40. As I mentioned, acutely, an RV can generate up to 60. So this doesn't really help us. This could be acute or chronic. Maybe it's more likely not chronic. And again, you can have RV free wall thickness, which I didn't measure. It's tough to see in my subcostal four-chamber view, but didn't appear thick. So maybe we'll go forward and say, well, this patient's in the ICU. This doesn't seem like a benign finding. Probably not something they're walking around with. This is acute, but it could still be cor pulmonale, PE, acute on chronic PH, or a pneumothorax. So I wanted to share with you that, as teasers for future talks, there are other ways to use your echo probe. So of course in ARDS, we'll usually have the x-ray first. So it won't be so helpful to be putting your echo probe and showing that there are maybe B lines suggestive of edema in all the lung fields. But you might have a patient acutely decompensating and wondering if they have a pneumothorax. And sometimes the chest x-ray isn't the clearest about a pneumothorax, although if they're in the unit decompensating, it probably will be. But sometimes you could get your hands on an echo probe sooner than you can get yourself an x-ray. And here you might see a sign of no absent lung sliding, which is a clue, but certainly not specific for a pneumothorax. If you put an M mode on that, you'll see this bar sign, which confirms that there's no lung sliding. Again, this is something that we'll talk about in one of our thoracic ultrasound lectures. But right here, you'll be seeing the lung point sign where the lung moves in here. You're getting lung sliding, but no lung sliding here. This is 100% specific almost for a pneumothorax, at least at this location. And maybe then you get your x-ray and you're able to see that this patient has a super large pneumothorax, but it's possible you could have intervened on this already in a patient in the right clinical context using your echo probe. Is it a PE? Well, maybe you'll see this clot in situ and say, this clot on the RV and say, okay, this is almost certainly a PE. I'm seeing a clot in transit, right? Maybe you don't see the clot in transit, but maybe you got lucky and you were able to see your PA artery very well in the parasternal short axis view and actually saw a saddle embolus. So maybe not even in transit, but having reached its destination. Maybe you're not able to see anything on the echo, but you're actually savvy with vascular imaging and you're able to see that there's a significant DVT. And maybe it is old, maybe it's new, but regardless, it will help you guide whether or not you want to anticoagulate this patient. So there are other ways that your comprehensive echo and critical care ultrasound skills are going to inform your interpretation, perhaps of even just an echo or an acutely decompensating patient. And so in summary here, I'm just going to share I'll share this slide or this image. It's already on Twitter, but you can freeze your screen and save this if you'd like. This is just a summary of all the different things that we talked about that you could see at each of the different views in the echo. Not shown is the RV inflow view, which we'll talk about when we discuss TR and RVSP. Some of the pitfalls that we discussed: ensuring you're on axis, avoiding being foreshortened, knowing the features of normal and abnormal, being wary of using focal quantification to describe global function. You can do it, but use the TAPSE to describe global function when you, using your eyes, also believe that that TAPSE represents homogeneous global function. McConnell sign does not equal PE, probably equals acute RV dysfunction. Epicardial fat could look like an effusion, and a moderator band might look like an RV thrombus. These are common pitfalls that you might come across when you're assessing the RV on an echo. You can freeze if you want to read some of these critical care echo 10 commandments, but they mostly mean that you have to know what you're capable of, what your skills are. You have to know what echo is and is not capable of, and make sure that you're on the right axis. Always see a finding from multiple views. Know what you're looking for, know what you're looking at, know what you are not looking at. What segments are just not in this view? Don't use POCUS instead of comprehensive echo, and reiterate that you should really know your abilities before making significant calls based on critical care echo. And that's all for this. And I'm sorry that I forgot to record this live and you had to get this this perhaps blander rendition, but I hope this is helpful, and please be in touch with any questions. Bye-bye.